Hello, I'm Dr. Makhlouf. I'm here in the suburbs of Atlanta visiting my granddaughter for her birthday. While she's asleep taking her nap, I decided to do a little video about gynecomastia. First thing I want to talk about is the fact that gynecomastia in male does not involve the same glandular tissue as you have in the female breast. And as you can see from these photos, one is a slide of a female breast, and you can see glandular tissue that is hypertrophy that it developed, and you can see duct tissue. Whereas in the next slide, if you look at it, you only see duct tissue development and multiplication, and that is what is occurring in gynecomastia. There is no increase in glandular tissue, only increase in ductal tissue. That's why we consider that gynecomastia is male tissue and it's not female glandular tissue. Now, when we evaluate gynecomastia, we're going to look at different factors. One is going to be how much fat there is versus how much male glandular tissue there is. The second thing we're going to look at is the size of the nipple and the size of the areola. The third thing we're going to look at is an estimate of how much extra tissue there is and how much we need to remove. And lastly, we're going to look at how lax the skin is and what is the position of the nipple areola complex with respect to the chest. So estimation of how much fat there is compared to male glandular tissue takes into account the examination and the feel of the tissue. Obviously, the male glandular tissue will feel firmer. The other thing that we'll take into account is when did the gynecomastia appear. If it appeared during puberty and never left, then we tend to be sure that there is glandular tissue. If the gynecomastia occurred later on, when the patient added significant amount of weight, then we know it's going to be primarily fat tissue. There are other factors involved and so on. Now, the size of the nipple and the areola is important because we have to decide whether we're going to reduce the nipple size or we're going to keep it the same, or whether we feel that when we remove the tissue behind it, it is going to shrink because it's not being pushed by the glandular tissue behind it. Once we have estimated the amount of extra breast tissue that is present, and as an estimate based on experience, we have to address the skin laxity and the position of the nipple areola complex. Usually, once we remove the tissue behind, the skin is going to tighten up, and we usually don't have to adjust the position of the nipple areola. And it's very important because any reposition of the nipple areola complex is going to involve scar tissue and different incision and skin excision, and that does not usually result in very nice scars. Also, it is important to understand that as a surgeon, we are concerned about the circulation of the nipple. So it's not so easy to just say we're going to move it, because we have to think about the blood supply. There's no blood supply coming from underneath, and so some of the circulation to the nipple has to come from the tissue around it. That in itself limits the extent of dissection we can do. Now, let's talk about the size of the areola. As I mentioned earlier, there is definitely an element of shrinking of the areola once the tissue behind it is not pushing it forward and stretching it. That usually is enough for most situations. We usually make an incision in the lower quarter of the areola, so that if you would imagine the areola the face of an old-fashioned watch, where on the top you have 12 o'clock, on the bottom you have 6 o'clock, and on the one side you have 3 o'clock and the other side you have 9 o'clock, we are going to make an incision between 4 o'clock and 8 o'clock. Then we're going to elevate the nipple with approximately 1 centimeter of tissue behind it, so that it does not end up, the nipple areola does not end up in a depressed area. And then we're going to remove the tissues around it. Now, if we have decided that the nipple areola is too big and we want to make it smaller, we have options of putting a suture in a circumferential fashion around the areola and cinching it together. That suture is deep and is either permanent or semi-permanent, and it will allow the areola to be smaller. If this is felt not to be sufficient, then we will need to remove 2 triangles of areola, similar to taking 2 slices of a pizza and sewing it together. And this is what the video is there to show you. If you have any questions about gynecomastia, please don't hesitate to call us in the office at 847-297-8001. Have a great day.